Assalamu alaikum. Good evening. I would like to congratulate all my colleagues, those who passed the exam, and I look forward to, as anyone, our aim is to pass the next exam, and I wish you all the best of luck. I'm very grateful to Dr. Mohammad, Dr. Iman, Dr. Mahmoud. They were a fantastic teacher, and I've learned a lot. And as they say, you learn until you are dead. I'm still alive, and that's why I'm learning, and I will continue learning. I'm going to share with you
Excellent.
the Kuwait project, and which is high alert medication.
Yes.
It is a quality control project, depending on the focus PDCA. It's complying with the independent
Excellent.
check for high alert. Obviously, focus begin with the find an opportunity to improve, conducting an independent double check when administering high alert medication is vital to ensure that the patient receives medication in the safest manner possible. After 2 reported adverse events on our hospital on a high alert medication administration errors, and upon analyzing the data, we realized the percentage of compliance with independent check was only 21%. So we organized the team, which is with my colleague, Dr. Cindy, Dr. Amal from Dr. Nafisa is an anesthetic registrar, was very helpful to review more than 300 files. And I am very grateful also to our quality department, Mrs. Safa, I have encouraged her, and we are sponsoring her to attend the next course with you, Dr. Mohammed. And this is the lady whom she is originally a midwife by profession. Divya, she's already on the course, which is coming in 4th of January. Divya is one of
Inshallah, she is most welcome. She is most welcome.
Quality assistant, Divya, which hopefully I will send her the next time.
Excellent team with great leader. You are all most welcome.
So we need to clarify the process of root cause analysis. So we started with the flow chart. I'm giving you what usually happens, was supposed to happen. Patient admitted to OR, collect the medical history, birth, medical history, past history, and then the high alert medication is required. If it's not, then it's not a high alert, and that's not going to be, yes, the history all will be there, but it's not going to be a double checking. But if it's yes, identification of the medication, the dose, the allergy, and proper documentation by the RNA, the nurse, and the physician signature is mandatory. Here, the nurse is usually an anesthetic nurse, and medication administration after double checking, that's verification has happened, then they will be given. So, unfortunately, the flow chart, that's where it went wrong. If we look to the patient admitted in the OR, identification, the dose, the allergy, collect the history, ensure familiarity with the patient, diagnosis and medication, confirm the drug, the route, the time, the reason, double checking, that's the norm. And medication dose and adverse effect. But if that not happen in these cases, then obviously monitoring of the patient adverse effect became critical where the problem had happened. So what are the scenario now? To discontinue the drug, or if no, sometimes they continue to lower the dose to avoid that side effect. And that could, the dose could be adjusted without any, if there is no any serious risk, and then they carry on because they realize there was a mistake, they double check, and they look into the weight, the height, and the new dose, and if there is any evidence of miscalculation, they have to readjust that in a lower dose and prepare the medication again, adjust the ideal dose, and definitely an independent double checking will be, and this is the time to educate about the patient and about the new dose, and everybody will be. If the medication in the other arm discontinue, yes, then identification of the new medication, the dose, the allergy, prepare medication, independent check again, check the medication again with the patient, and then you carry on the admit. So, and we realized that in 5 serious adverse, that's why we decided to run an audit and see where is the failure. And that's some of the flow chart I'm discussing with. And obviously, we decided to do.
Yes. Please, Dr. Bakr, please return to the last slide. Yes. I have a simple question about the steps of identification of medication dose and allergens and other blue steps. Why you are putting them in rhomboid shaped instead of rectangle, although they are simple steps? What is the idea?
Yes, I agree with you. You should have put it in that. So that's something I should look into that. Yes, I agree.
Okay. Okay. The next thing that the 3 rhomboid shapes in the second grid of in the second row of discontinue the drug, yes or no, then continue at lower dose. The step of continue at lower dose, it should be rectangle, not rhomboid. We use rhomboid if we have multiple choices, either yes or no or so on. But here, continue at lower dose has one end, so it's better to be rectangle, not rhomboid. Okay.
Okay. Thank you.
Okay, thank you. Next slide. Excellent flowchart. Thanks.
Okay, next slide. Sorry.
Yes, Cybook.
I'm going to Cybook. Cybook obviously is dependent on the supplier, the input, the process, the output, and the customer. And the supplier, the pharmacist.
Excellent. Clear. Clear. Next slide. Yes,
okay,
clear.
Then
next.
This is our route. Shall I carry on this?
I want to yes, the fishbone is very clear and very excellent, but I want in the discussion here to know the conclusion. From your point of view, Dr. Abu Bakr, what is the main cause, the main root cause of the problem from your side? Which side is the biggest side responsible for the problem, more from your point of view?
The procedure. We had a big failure in the independent check process.
Excellent.
I could see you later on the graph and how was poor is that.
Excellent. This is the value of fishbone diagram, to know where is the vital area for the cause. Thank you. Next.
And obviously, we select the outcome for the improving the communication with patient, continue monitoring for errors, providing clinician with decision support and information tool, improving the standardizing mechanism labeling and drug-related information, voluntary self-report data include changing the culture to focus on the system issue rather than individual deficiency, and having explicit and visual quality management system responsive to these data. The process focus factor include minimization of distraction and interruption during the medication administration, using equipment correctly, and assessing the monitoring of the patient responsive to the medication. That's the select.
Okay.
And Dr. Amal is my colleague, will continue.
Thank you, Dr. Abu Bakr. You are welcome. Welcome, Dr. Amal.
So I'll take over from here. And this continuation of the project improvement, we will apply the tool of PDCA. And PDCA is the plan and what we will do, as well as the comparison and the action, which will be conclude the PDCA. So the plan here, patient safety team shall liaise with the stakeholder and assume responsibilities to ensure compliance to this protocol, to organize training program to raise the bar of the compliance itself, and to conduct a similar audit during December 2020, which we're just starting for the HPU. So what we need to do to that, to reinforce the high alert, which is AHM medication policy, as well as conduct a random observational audit which I will show what's the tool we used for the audit. For the surgical cases in the OR by identified clinical staff. Concerned head of department or the manager will discuss with the staff the trend of how the medication administration should be, or the administration error occurred, and create a new process to correct the mistakes and avoid recurrence in the future. Head of department emphasize on the IDC compliance during departmental meetings to remind the staff, as well as a stakeholder will need to revise the policy of the high alert medication and related forms list to avoid this error to happen in the future. Then we go to the comparison. The comparison where we had the 3 audits, which is one done in 2018, second 2019, and the current one in this year. And we found that there was an improvement, which if you see here, nice. we have improvement between the 2 years. And then in 2020, because of increase of number of patients from 62 to 84, of course, the percentage will showing is 55, despite the improvement of the previous year. So the action which will be taken, how we're gonna act on the result of the comparison and this audit. The manager used the information on the root cause of the error for training, as well as monitor the staff who are habitually not compliant with the IDC, which is the resistant staff, as well as bring during the departmental meeting true life examples to remind the team, sharing learning experience and audit results with the staff. High alert medication policy and related forms lists need to be revised, review floor stock and take the necessary actions depend on the audit results, allocate an area for a high alert medication preparation, which need to be quiet and separate with no interruption, extend the audit to cover the HPU and SCIBU, to cover all areas other than OR, which is like dissemination and implementation in all other areas, with continuous audit to complete the cycle of 100% compliance around the hospital. Dr. Bakr,
excellent focus, BDCE. Excellent.
This is the audit tool which we used for collecting the data in the 3 audits, which was the same questions and the same data in the last 3, and it was focusing on the OR, done in OR, and this is in the 3 audits done throughout the years.
And
the next one, there's a chart. The next slide, Dr. Abu Bakr. This is the chart to show the comparison and to show the results in a linear chart, which is independent.
Excellent usage of display charts. Excellent.
Yeah, and next to it, there's the bar one, which showing the percentages in bars.
Excellent.
And
just a second. Yeah, I will just carry on here. I just share with you. This is the histogram. Thank you, Dr. Amal. That's very great.
Thank you, Dr. Amal. Please return back the scatter diagram. Kindly tell me which relation did you show through your scatter diagram?
The scatter diagram is mainly, sorry, it's just,
yes.
This, the color is showing the year 2018, 19, and 20. And because if you look into 2018, we have double checking was nearly 21%. So we had a great failure. You can see here, our blue is falling down. At some, the notes, we review about 65 notes. Some of them are to good standard, and then they are always poor below. And that's, and then 2019.
Yes, I think, yes, I think linear and bar chart were sufficient to represent these statistics, but I think a scatter diagram is not applicable on it, as you know. Scatter diagram is mainly to denote the relation between 2 variables. So here we have 1 variable, so scatter diagram won't be helpful enough. Okay.
Fair enough. That's why I asked you that day. I said this.
Yes.
Okay.
And as we deal that, some sorts of things can be not applicable, so no problem at all. Okay, thank you. Next.
Next, I'm going to go for, I hope that will do the justice. We try to do the
what about Barito? You did Barito about what?
About the medication name, about the medication dose, and the expiry date for this. These are the parameters we look into it. Where is the failure happening? The failure happening,
yes.
Double checking. Sometimes they don't realize this is the right drug. Remember when you taught us about the drugs, you have to be very careful. This may sound the same or they look like.
Yes.
So there was a failure in that area. There's a failure in the dose in this incident. And there was a catastrophe one where the expiry date was not there. So we tried to.
Which were the which was the vital few and which were the useful many about these drugs?
So if we code that, this is the line will be here. So it's mainly this is the could you see my arrow? This is the 80 and this is the 20.
Yes, the main problem we're in the medicine name, then the dose. So the name is a vital few issue, right?
Yes.
Okay, thanks. Next.
So yeah, just wanted to. We tried also to do a control chart, and we put 3 standard deviation to the maximum control level, and the minimum 3. And then we put all the years here, and that's how our control chart. I don't know if it is give an idea about.
Yes, the problem in this control charts that we want to make the upper control limit and the lower control limit very clear, and the midline between them very clear, and to make our linear operations where the site of our linear operation within our control chart we want to see whether it's within the control limit between upper and lower control limit, or above or below, or so on. So this control chart only needs to make upper control limit and the lower control limit more clear. Okay. Next.
Next. Dr. Cindy.
Okay, thanks, yes, Dr. Bakr.
Thank you so much.
Welcome, Dr. Cindy.
Thank you so much, Dr. Mohammed. So here we're talking about the quality control process. So our subject here is the high alert medication, and then the established measurement that we found in 2020, we have 21% compliance with the independent double check. And in the OR, this have been changed to 55% by the year 2020. And then for the predetermined standard of performance, our target is to have 0% of error with high alert medication and in the double checking. For the measure actual performance, we would do this by reporting. And then in comparison with the standard, we find that after checking the final results, education is required as a mandatory action to register nurse and physicians to avoid any risk or harm to the patient, and action taking that specific physician training and pharmacy, like double check the dose and input weight and dose in label comments for registered nurse double check plus proper education.
Excellent.
And then we have the FEMA, the failure mode effect and analysis.
Yes.
So we are here, our FEMA is to reduce the percentage risk. By our aim is to reduce the perceived risk by 50% in 6 months for high alert medication administration in OR. So the first step is physician order medication. What happened here, or what went wrong in the emergency cases that requires a rarely used drug, which would affect appropriate choice of dose. This is due to rare use of the medication, and the action needs to be taken is information attached to the medications available. And then we have the physician chooses the right order set but selects incorrect dose, which would affect sub or super therapeutic dosing due to inattention to detail or distraction, and action taken pre-prepared doses. And then we have for pediatrics patients, physician chooses dose based on wrong weight or age, which would lead to super or sub-therapeutic dosing. And this is because the stuff is really common with the adult, the dose for the adult, and they're not common used with the peds. So action taking information attached to the medications available. And then we have the verbal.
Dr. Sandy, I want to ask a simple question. About the emergency cases that requires rarely used drug. What do you mean about detection level is 2? From your point of opinion, is that means detection is high or low?
No, it's low. Sorry, it's high. Detection is high.
Yes, excellent. I want you to make a very good edition, very simple edition on this very good FEMIA to make ordering according to the highest risk priority number, then lower, then lower, then lower. Okay. So you at first make the verbal orders at first, number 1, then a physician chooses, and for pediatrics number 2 and 3, then number 4, which is 100. What is the failure mode of 100? It's not clear for me.
Sorry, the 100?
Yes.
Which one? The
name of failure mode is absent.
No, this one for pediatrics is the effect sub or it's the same. I think under the pediatrics patients.
Okay, but I think this empty box must be filled with failure mode sentence.
Okay. We have to merge it with the other one. Yes, we'll do this.
Okay. Next.
Okay, so the next step is pharmacist verification of physician order. So the failure mode here is no review by the pharmacist, which would affect the patient to receive wrong medication or dose. And that would lead to, this is caused to register nurse override due to delay or impatience, medication given without pharmacist review. And the action needs to be taken education to the registered nurse staff to understand the risk involved. And then we have the pharmacist doesn't identify patient weight or dose at order verification, which would affect wrong patient drug dose form. And this is due to inattention to detail, distraction, and or tracker to be updated. And then we have the actions need to be taken, develop computerized maximum dose alerts.
Excellent.
And the last step is medication administration. So our failure mode here is clinical staff doesn't verify medication barrier to administration. And the effect on the wrong patient medication, dose or route, which was due to urgent clinical need or poor practice, and the action needs to be taken, auditing and re-education. Then we have the clinical staff doesn't confirm dosing before administration, which would affect the potential for serious life harm. This is due to relies on memory or trust between colleagues and or those not use the resources available to look up and confirm indication routes and doses. And the action needs to be taken is education to staff, provide educational and support resources like computer desktops, clinical pharmacist review, and all IV high alert medication independent double-checked prior to administration. The last step is clinical staff doesn't perform independent double-check on high-risk med, which would affect loss of final safety check before administration. This is due to unfamiliarity with high-risk medication, experience with drug familiarity makes independent double check seem unnecessary or redundant, and the action needs to be taken is reducing need for independent double check on the low-risk drugs or increasing compliance with the high-risk ones. Develop advisory check and computer to drive independent double checks and all IV med double checked.
Excellent. And this is the highest risk priority number.
Yes.
Yes. Excellent.
And that's it. Thank you so much.
Good.
Hopefully we covered all the
thank you.
All the areas.
Excellent. And within the excellent time. Excellent projects. Excellent work. Thank you all. Thank you all. Thank you very much. And you deserve the full mark. Thank you so much.
Thank you very much. Thank you, Dr. Mohammed.
Thank you so much.
Congratulations.
Thank you.
Congratulations. We are waiting for your CPHQ final certificate, inshallah. Congratulations.
Thank you, Dr. Bakr. Thank you, Dr. Amal. Thank you, Dr.
Thanks, Dr. Bakr.
Thank you all.
Dr.
Thank you.
Thank you.
Bye-bye.
Thank you. Goodbye.